3, 2, 1.
Good afternoon, everybody, and welcome to our Digital Healthcare Transformation webinar. We're just waiting for a few more people to join, and we'll get underway in no time at all. Everyone will be placed on mute, but we do encourage you to ask questions with the Q&A function. And do let us know who you are, what you hope to achieve or learn from today's webinar, and say hello to everybody. The webinar will be recorded, is being recorded now, and will be made available to everybody that's signed up on our webpage. And don't worry, if you've got a question, just ask it at any time. We'll pick those questions up in our Q&A panel at the end. Okay, I'm going to hand you over to our chair for today's session, Helen Robson. Thank you.
Good afternoon and welcome. This is the fifth in a series of Connect Health Change webinars, which are about making and embedding transformation in healthcare. Previous webinars have covered a range of topics, including first contact practitioner, peer management, and COVID rehabilitation. Today we're going to ask each of our speakers to speak for about 7 minutes, followed by any immediate questions. But we'll take the majority of the questions at the end, so please do post your questions in the Q&A section. We're really honoured to have an impressive lineup of speakers, and you may well have already seen their bios, but if not, you can find them on our webpage. So today we're going to be hearing about developments in digital healthcare transformation. It's an essential topic based on both the NHS Forward Plan and also the TOPOL review, which was commissioned in 2017 by Jeremy Hunt, who was Secretary for Health at that time, to look at how the NHS workforce can deliver the digital future. We're all aware that as people live longer, but also with more long-term conditions, there is a significant challenge of the increase in the demand for healthcare. At the same time, there is change in public expectation about how we interact with technology in healthcare. Interestingly, 90% of the population regularly accesses the internet, yet less than 25% have registered for digital access with their GP. So again, we see how we can face another challenge and how we need to meet everyone's needs by working together. The NHS long-term plan identifies the need for more healthcare workers to respond to this challenge, this increase in demand. Digital healthcare technologies, digital medicine, artificial intelligence, and robotics are a few of the new means of addressing the big healthcare challenges we have across this next century. The TOPOL review suggests that these technologies will not replace healthcare professionals, but will enhance them, giving them more time to care for patients. And we're going to hear an awful lot about that through some of our speakers today. Some professions will be more affected than others, but the impact on patient outcomes should in all cases be positive, and we should ensure that we empower patients to participate fully in their own care with all transformation. The next decade provides an opportunity to advance technology in healthcare significantly. However, successful implementation will require investment in people as well as technology. There is a need to ensure that the healthcare workforce is engaged. That might be perhaps our biggest challenge. And we must support the healthcare workforce through this rapidly changing environment, as well as ensuring our patients are involved in the developments. With this in mind, I'm going to introduce you now to the first of our speakers. This is Abby Phillips. Abby is the Head of Innovation for the Economy, Skills and Natural Resources Group for the Welsh Government. And she's going to discuss the rationale behind the Welsh Government's Digital Solutions Fund and some innovative ways to use digital technology in response to coronavirus. So I'm going to hand over to Abby. Thank you.
Thanks, Helen.
Good afternoon. I'm Abby Phillips from the Welsh Government, as Helen said, Head of Innovation for Economy, Science and Natural Resources, previously working on technology and innovation in the health side. So I guess I've sat on both sides of this coin, really. If you could just move to my next slide, please. So I thought it'd be helpful to give you sort of a brief overview of the policy landscape in Wales. I think, most pertinent to this is Welsh Government policy decisions and delivery are underpinned by our Wellbeing of Future Generations Act, and that recently celebrated its 5-year anniversary. So the Act applies to around 40 public bodies in Wales and puts a legal duty on them to act in accordance with the ways of working while delivering services and interventions to the public. And that those services should be contributing to the achievement of the 7 goals that you see on the wheel-shaped diagram on the slide. Particularly important to this work is the area of a healthier Wales. Projects we've supported also reduce travel and improve equity. So, obviously work towards those other goals also. About 2 years ago, we published a long-term plan for our health and care in Wales, and a key commitment of that plan, A Healthier Wales, was to increase investment in digital and data, looking at opportunities to move away from hospital-based care to a model which focuses on a more partnership-based approach between patients and clinicians on well-being, prevention and self-management. I think it's fair to say we are clear that people will always be at the foundation of health and care delivery, and that people won't always choose digital services. They will want face-to-face interaction, but to have that choice is really important. We're also keen to move to services where we can predict outcomes. So using things like PROMs and PREMS data will be a key feature of this shared decision making between patients and clinicians. And I think one of the key aims related to this project was to develop an online platform which helps citizens have better control over their health and well-being, where we'd see products like Phio now being offered from a single place for citizens to access as they need to. And then last but by no means least, our economic action plan, Prosperity for All, is our plan to grow our economy in Wales. And obviously automation, artificial intelligence, digitalisation, innovation and skills are key features of this document. So we recognise that people will need new skills, not just to respond to increasing digitalisation in the world of work, but also in their daily lives. And if anybody's interested in seeing some of the activity we've done specifically around digital health, and the Phio Now project features on this, our digitalhealth.wales is a great resource which contains information on projects that we're working on, programmes of support available to companies and clinicians, as well as news and events. If I could just take the next slide, please. So our Digital Solutions Fund, the Welsh Government, in particular ministers, were really inspired by the overwhelming support that was received from industry over the COVID surge period in March. So over 200 sort of companies came forward with ideas, offers of support, products, and I think that the issue with some of those was the variation in the level of detail received and their readiness to market. So we decided to hold an open and transparent competition which focused on specific issues or problems that would enable us to make a fair assessment and identify some of those that we could take forward. The Digital Solutions Fund was created to rapidly pilot new technologies, but technologies that already had a market presence and that had any of the kind of necessary regulations that were needed that could support the NHS Wales COVID-19 response, as well as supporting digital transformation of healthcare. It was designed to understand what was available, identify the best projects and pilot in a short time scale. And we actually modelled it on the TechForce 19 competition that was run just before us by NHSX. So the themes for the competition that you can see there on the slide were proposed by health boards, so are totally based on the kind of NHS needs that were identified by frontline clinicians and digital colleagues. And we received 142 proposals to that call. We got 27 assessors on board, all of whom were kind of frontline clinicians involved in NHS delivery. We received 15 pitches, so it was a big effort to get down from sort of 142 to 15, and that resulted in 5 successful projects. So these included obviously the online physiotherapy tool, but also things like online resilience training for NHS staff, and remote monitoring of COVID and chronic conditions that could be affected by COVID. So each project will provide an evaluation based on impact within the local setting, but the actual programme is underpinned by an academic evaluation to determine what has worked well and what lessons have been learnt from the programme as a whole. So I think it's fair to say that COVID has accelerated delivery of certain initiatives, and it would be great to retain that pace while ensuring we're doing things correctly, and the programme level evaluation is designed to do that. So thank you very much.
Thank you, Abby. Just a quick question, really, to pose at this stage. What do you think the future holds? What do you think you're, really kind of around the broader policy context and the direction of travel with, for yourselves in Wales?
So I think we're going to start seeing a lot more digital health delivery. Accepting that obviously not everybody can access digital health delivery. So, we've invested a lot in Wales in upskilling people. We've put a lot of devices out. So our Digital Communities Wales programme has been really active in getting devices out into the hands of people who haven't had them previously. And that's included people like school children, older people, care homes. So I think we will continue to see that growth, but mindful of the fact that human interaction is still very important, and making sure that some of our more, sort of digitally disadvantaged citizens have got access. But I think, yeah, there's a long way to go yet.
That's great. Thank you very much, Abby. We'll speak to you again in the Q&A session at the end. Okay. So we'll move to our next speaker, who is Zoe Brewster. Zoe is the Assistant Head of Physiotherapy for CUMTAF, and I'm going to get the next bit wrong, I'm sure. Morgan, I'll let her introduce that because my Welsh is just not good enough. But she's going to discuss the practicalities of how the Digital Solutions Fund actually has helped enable AI to offer fast-track access to healthcare and how it's been embedded with the health boards. So welcome, Zoe. I will hand over to yourself now.
Hi, thanks, Helen. Good afternoon, Prynhawn. My name is Zoe Brewster. I'm the Assistant Head of Physiotherapy in CUMTAF Morgannwg University Health Board. We cover a number of areas across South Wales, and I will be sharing with you a little bit today around my experience on the ground of embedding physiotherapy now within our MSK services right in the middle of a pandemic, which has been really interesting. So you've heard from Abby about the kind of strategic overview of where this has come from and why, and I'll share a bit more about the practicalities, what the system is for those that haven't seen it, and a bit about our experience to date. It's been a whistle-stop tour. So if we can move to the next slide, and I'll share some examples of what this looks like for us. So for those that don't know, Physio Now is a clinically led chatbot system which allows remote triage. So certainly meeting some of those initial ideas that Abby shared with you around what we're trying to achieve and moving out of hospital. So this works on a 24/7 basis and has been tested in both Welsh and English, which is really exciting. One of my colleagues in West Wales has been part of the bilingual test feature, which is really important here for us. This is about getting it right first time, which is really about rationalising our services, being clear that everybody gets what they need and at the point that they need it and where possible in the community. And this is a digital option for what used to be a paper-based system, which is a really big step in the right direction. You can see some examples of what those kind of chatbot conversations look like from a patient's point of view. They really do feel like they're talking to a physio, and it's very, very interactive, and we'll see a little bit later on what the patient's feedback looks like. So we pop to the next slide, please. So we've looked at, as part of the pilot, we obviously have to demonstrate the value of Physio Now. So on your left is what our normal standard MSK pathways look like, which probably looks quite similar across the UK. So I've worked in a number of places in England and in Wales, and to be honest, they don't look that dissimilar. So we take a referral, it gets triaged by a clinician, our administrative staff book the appropriate appointment, and then they'll obviously normally come in and see a clinician. Obviously, COVID's changed quite a lot of that, and we're not doing our usual everything is seen face to face on the first appointment. So as part of the Physio Now embedded within the system, the purpose being that patients can self-refer any time of the day or night just by simply clicking on a link. You've seen the screen of what it looks like, and it's very, very user-friendly, very attractive, and the patients can fill it out in sort of 10 or 15 minutes, very much in their own words and how they're feeling about their condition, and goes into lots more detail. Because the triage system has these advanced clinical decision trees built into it, it means that the triage gets then straight to the administrative staff and they can book an appointment based on the triage. So that takes a small step out for the clinicians having to triage. Also, because of the depth of the triage, we get good detail from the patients, and that can help support some of the subjective assessment. There's potential opportunity to look at reducing the initial appointment time on that basis, but that's something we'll be exploring further in the future. So there are potential opportunities around savings for both clinicians and administrative staff. We move to the next slide, please. Thank you. Obviously benefits the patient. We've shared a little bit about that, and I'll share with you some more examples of our patients' feedback. Moving straight from a paper system to electronic means patients can access it at all times of the day and night, and we've got some good evidence that that's definitely helping. Patients will then be triaged as urgent or routine. No one has to leave their house at this point, which is great. Certainly COVID safe, which is great, and very, very convenient. Our clinicians then have the opportunity to have that information to hand before the initial appointment. We found that's really useful for things like students, so they might want to do a little bit of swatting up the night before. What am I going to see tomorrow? And that will help them to plan their assessment as well. It gives us a bit more opportunity to spend really good quality rehab time with the patients, and I think post-COVID that will potentially see some more benefits as well. Obviously, benefits around the wider healthcare system. We know our GP colleagues are using things like e-consult, and this is another example of that. Thank you very much. If we move to the next slide, we'll be able to share with you some of our findings from patients, and I think we touched on about where this fits in an all Wales basis, and what digital literacy and age groups really, the first thing that people say when we say digital access is, oh, that means a lot of people can't do it. And actually the evidence that we found during this pilot since we started in the summer was that at least 44% of our referrals have come from people over the age of 60, which is a really good sign for us, and certainly helps to develop our services in the future, because this is obviously a large demand for MSK physiotherapy. And as we say, age is just a mindset. There's some more patient feedback if you move to the next slides. Thank you. So our patients have been asked to just make a simple, would you recommend this service to a friend or family member, and 89% of patients have said yes. Small number have said no, but a small number have said that they can't decide. So I think that that helps us a little bit. And also 33% of our patients are filling out these referral forms and having this conversation via Physio Now outside of core hours, which again really helps us to understand more about our services and what the general public need. And I think we're all probably in a very similar environment. We're all working people and trying to access services that are 9 to 5. I suspect challenges a number of people. So that's a really good bit of data that helps us to inform the future. Thank you very much. Can we move to the next slide? I'll just leave that up there for you to see in terms of the types of feedback we've had. And on the next slide, we've got a little bit more feedback from our patients. So I'll leave that for you and hand back to Helen.
Thank you, Zoe. There's some really interesting kind of facts and figures there, and I'm sure we can enlarge on some of those in the Q&A session later on. But for now, just if you could, what I was wondering is, what do you kind of think is next for you guys? What's next? What's kind of your vision for your digital health transformation within your services?
Yeah, so this is top of the radar for lots of people, and I'm sure lots of MSK clinicians everywhere really. We know that the demand for our services is just going to grow, the ageing population and all of those other things that we're all very, very, very familiar with. We're really keen to continue to work with Connect Health with this Physio Now, moving forward to create a self-management element to this this system, where we know things like, I've twisted my ankle. Well, actually, you've answered these questions, so we're going to give you these exercises to get you started. you may not need to come into a department, you may not need to come to a face-to-face appointment, and really I think the future's bright in terms of the digital movement.
That's perfect, thank you, Zoe, and I definitely have some more questions for you at the end. So thank you very much for that piece. If we move on to our next speaker, who is Peter Grunbergs. Pete is the co-founder and chief medical officer for EQL, and he is going to discuss the appropriate use of AI in MSK medicine and the potential of how that can revolutionise healthcare practices, customer experience and health outcomes. So move to Pete. Pete, can you hear us? Seems to be a little bit of a delay with Pete. So actually, Zoe, could you would you mind if I asked you another question whilst we get Pete back sorted? Is that okay?
No, of course.
So you mentioned around the students. How do you manage the governance around your students accessing the systems? I know from a few different webinars that I've been on that actually some of the trusts are not very keen on allowing students to access Teams, also accessing some of the clinical systems. So it'd be really interesting to hear your perspective on that.
Yeah, so we have a long-standing relationship with our Cardiff University students. We take a large volume of students every single year, so having students is pretty embedded in our services, and we've got really robust clinical governance structures in place because we have mentoring and training for those clinicians. I probably should have explained, so the Phio Now triage system that currently sets up through the pilot but essentially churns out a PDF document that then just comes into our referral system. So it gets managed in the same way that our other referrals are managed. So in the same way that we have clinical governance structures in place for our students managing new patient referrals, watch one, do one type setup, or doing a subjective assessment that's a watched assessment, that sort of thing. This is no different. They would look at the document beforehand, which is often much better than what they would have had before. Anybody can turn up and the referral says it's a knee, but it's actually something completely different, whereas Phio Now has kind of done all of that bit for us. So in fact, it's probably safer.
That's really helpful. On the issue of safety, Zoe, I've got another question for you. You mentioned that a number of your patients were completing it out of hours. Are there a percentage of those that are completing it out of hours that are then needing to access urgent care? Is that pathway working?
Yeah, so the clinicians that have been involved in developing Phio Now service, which I won't take any credit for whatsoever, I have to say Connect Health's clinicians have clearly spent a significant amount of time developing these clinical decision trees, and that's been part of it, is getting that really robust, things like red flag questioning, etc. So in terms of what comes out of the conversation, it gets directed to a number of routes. So if they are not a patient that needs to be managed in physio, if this is an acute medical problem or something that does not sit under the umbrella of physio, they will be advised to contact 111. So that's a safety net in place for them to then be directed elsewhere. Early signs from our pilot is that that's very, very small numbers, which fits pretty much with our experience in MSK. Generally, the numbers are small, but it's obviously something. We have the opportunity, the next option is that it generates an urgent referral. We pick our referrals up every day. If it was clinically triaged as urgent, our admin staff would book that in for a telephone consultation within a couple of days. That would be the same as any other urgent referral. And then a routine referral would be a letter that we send, which is how we manage our referrals now. Does that answer the question?
That really does. Yeah, that's really helpful. Thank you. I will I'll let you have a rest, Zoe, now, and I will come back to you later. But I believe Peter is ready. Peter, can you hear me?
I can hear you, Helen. Can you hear me?
I certainly can. So I will reintroduce Pete. So Peter's from Equal. He is going to discuss the use of AI medicine. Can we have his slides up, guys? I'm not sure whether it's just my view, but I can't see the slides at the moment. Oh, there we go. He's going to talk about the future of AI and how it can revolutionise healthcare. So Pete, over to you.
Perfect. Thank you very much, Helen. Yeah, look, it's a great pleasure to be able to talk to everyone this afternoon about the appropriate use of AI in MSK healthcare, and also, as you mentioned, how we can use AI to further improve health outcomes and user experience. So next slide, please. So what's the problem? Well, a significant proportion of the healthcare system is spent dealing with MSK problems. It equates to roughly 30% of a GP's time and generates in the region of 7 million physiotherapy appointments annually. Typically, it can take time to get in front of a physiotherapist, as we've already been hearing about. And as we know, waiting for an appointment can add cost and cause injuries to deteriorate. Next slide, please. So, how can digital transformation help? Well, digital transformation has the potential to reduce waiting times, increase capacity, and deliver more cost-effective intervention. More importantly, by having access to healthcare through readily available technologies, we have the ability to really improve things like health outcomes and reduce health inequality generally. And I firmly believe that AI can play an important part in both of these potential outcomes. So essentially, AI has the ability to analyze data, and in doing so, we can effectively create useful insight. This data could come directly from a patient or a user, or from a clinician, or from research. And effectively, by creating models that can analyze this data, we're able to create efficiencies that relay both useful information to the clinician and engage the user by interacting with them in a way that is meaningful and also personal to their current situation. Next slide, please. So we currently have a solution called Phio that provides a digital-first MSK support tool. Now, Phio is the technology that sits behind the PhysioNow platform, and Zoe already did a great job of outlining the functionality, but I mention it again because I think it's really relevant when it comes to our vision of collecting important information for clinicians, whilst also remaining accessible and engaging for users. Next slide, please. And I think, again, as you've already been hearing about, but we've really been able to evidence this, not only through our high levels of clinical acceptance, but also through our user engagement and the fact that we have seen no clear evidence for a digital divide in terms of age being a limiting factor. And that is something that we're really proud about, and it's something that we've worked really hard to try and establish. Next slide, please. So what's next for Equal and for Phio ultimately? Well, we're currently in the process of developing an innovative, fully AI-powered solution for those with MSK pain. Next slide, please. Now, this differs significantly from the current version of Phio, which uses no AI other than conversational communication for this human-like interaction. With the new product, the patient and their outcome are still very much at the center of what we do. However, with this product, we've built an AI model that uses probabilistic modeling and statistical inference, coupled with expert opinion and literature. This allows the model to reason clinically, giving an indication on things like differential diagnosis and, where appropriate, the necessary course of action or course of treatment. This product is not currently on the market, but we hope to make some announcements about it in the not too distant future. Next slide, please. And picking up on some other points around what's next and what have we got coming up. So another key focus for us was to really find a way for patients to safely and effectively manage their conditions from home. So many people are capable, are suitable, and also have the desire to self-manage their MSK problems. We're in the process of launching a system that encourages the user to take responsibility and accountability for their recovery. Patients benefit from prescribed exercise content, interactive dashboards, and tracking towards things like personal goals. Importantly, the system back-ends into a clinical provider, ensuring that those who need clinical intervention have it when it's needed. In developing the solution, we were keen to address a number of pain points for both clinicians and users alike. So on the one hand, you have clinicians who are keen to encourage patients to take ownership over their condition management, and not over-medicate with unnecessary treatment or intervention. That said, it's also key to provide a solution that relays structured clinical information that they can interpret and then where necessary, they can act upon. And then at the same time, you've got users who need to feel confident and empowered to take control of their recovery journey, whilst also feeling supported by the fact that what they are doing is right, and that if they need to speak to someone, they can, and if necessary, they can be directed towards another type of care. Next slide, please. So what does the future hold? Well, innovation is always very high on our agenda. Recently, we were awarded an Innovate UK grant to research and design an immersive technology that looks to bring patients and clinicians closer together when interacting in a remote setting. We intend to use a number of AI-based technologies to power this solution, and as ever, we'll be focusing on access, engagement, and presenting clinical data in a safe and meaningful way. A number of our roadmap products look to harness the power of AI and machine learning to accelerate recovery, increase capacity for clinicians, and create better health outcomes. But I think it's important to mention what another big aspiration for us and something that's a key objective moving forward long term in any event is to look at how we can really turn the tide on reactive healthcare and look instead at how we can create proactive solutions that are capable of identifying risk factors long before they become problematic. And again, AI really has the potential to revolutionize the market here, particularly thanks to its ability to detect and monitor seemingly innocuous signs and symptoms. Next slide, please. So I guess it takes for me to say thank you very much for your time. It's been a real pleasure presenting to you this afternoon. Thank you also to the team at Connect Health for hosting the session, and very happy to open up the floor for any questions.
Thank you, Pete. That was a really useful talk. First question from myself is, how do you think artificial intelligence will complement clinician behaviour and augment it?
Yeah, that's a really good question. I think, as I mentioned, the power behind artificial intelligence really lies in its ability to collect, analyse large data sets and then present back for interpretation. And I think it's that presenting back that's the key part, because obviously clinicians are the experts, and effectively what we're able to do is aggregate data in a way which is potentially meaningful, give insight. But ultimately, the whole point is that it's passed back to clinicians to effectively evaluate, sense check, see whether or not it's something that is potentially useful, and evaluate, and then incorporate that potentially as part of their practice. So I think I see it as another facet, another kind of tool that potentially sits with that clinician and effectively is there to be able to provide meaningful data and allow them to clinically reason in a way which hopefully has been enhanced through the insight that's been collected.
That's really helpful. With that kind of in mind, what do you see as kind of the long-term impact of technology like this on musculoskeletal clinical careers?
I think, again, another really interesting point and a very valid one. I think for me, whilst there are still waiting lists, and whilst there are still people who, first of all, don't potentially know that they've got injuries, potentially don't know what to do about them or where to go about them. I mean, the healthcare system at the moment deals with people that effectively understand that they've got an injury, they can do something about it, and so they're seeking healthcare in order to overcome the challenge. But I think there's a huge amount of people potentially that don't know about the fact that they've got things that can be resolved, that importantly can be self-managed. And as we know, MSK pain is a gateway for comorbidity generally. And so I wonder what the knock-on effect is for those people that don't proactively engage and seek healthcare when it's completely necessary or when it's absolutely necessary. So I think potentially that's where there can be some real impact, is just increasing awareness, increasing engagement early on, and in doing so then create a kind of culture where people are much more open to understand the need to engage in healthcare and are willing to do so themselves. And I think personally that's where I think there can be some real value added into the system.
Okay, that's really helpful. I think at this point we will move to our next speaker, Pete, and I will save some of the rest of our questions for the full Q&A session later, where we can have a multi-way discussion on it. So
Perfect.
Thanks for that, Pete.
Thanks, Helen.
Right, so our next speaker is Dominic Cushnan. Dominic, can you hear me all right?
I can, loud and clear.
Perfect, Dominic. So Dominic is the head of AI imaging at NHSX, and he's going to talk to us about AI getting it right in the NHS AI lab. So I'm going to hand over to Dominic, and then we'll have some specific questions at the end before we have a full panel Q&A session. Thank you.
Thank you. So if you can move on from the first slide, that'd be brilliant. Okay, so good afternoon, everybody. Apologies you can't see me in person. I did actually put on a suit and a shirt and wash my hair, so apologies that you can't get to see that gloriousness. But let me talk a little bit about the NHS AI lab and some of the work we've been doing and what we've been set up to do. So first off, thanks, Peter, for talking through the work you're doing around AI, because I think it articulates very well some of the things that we're doing in the lab to support innovations like yourselves. So if you go to the second slide of my deck, it'd be brilliant. So we are, as already mentioned by Pete, we're already seeing quite a great number of applications of AI technology, but more specifically needs to be done to fully harness these benefits, usually around the AI safety and the ethical use, and ultimately to deploy this at scale. And the NHS Artificial Intelligence Laboratory, the AI lab, was set up to address that challenge by bringing together both government, health and care providers, academics, and technology companies. And as this slide identifies, our focal point is accelerating the safe adoption of AI to the front line of health and care. And there are a number of mechanisms that we're doing that. If you go to the next slide, we have a number of key programs. I'm going to call out just 3 of them, specifically to start off with the AI in Health and Care Award. This is where we're funding and supporting promising AI technologies. So the AI Award in Health and Social Care aims to bring benefits to patients by combining the power of AI technologies with the expertise of the NHS to improve health and care outcomes. We have an award of £140 million available over 3 years to accelerate specifically the testing and evaluation of technologies that are most likely to meet the aims that are set out in the NHS long-term plan. We have just completed round 1, and we've had over 530 applications, and we have awarded over 42 projects made across the 4 phases of the AI award. We're now working with these winners to look at site selection, making sure that we match appropriate healthcare services to supporting the testing of each product. And if you're interested or interested in these technologies, you can find out more on the nhsx.nhs.uk website. And part of this program is ultimately about making sure that we can evaluate these technologies, ensuring that there is enough and appropriate evidence to make sure that we can deploy these technologies out at scale. We've just opened up the second round of applications. So it opened on the 3rd of November and it closes on the 8th of November. So if you're interested and have innovations or are a part of a site where you would like to come and use AI technologies, please do go through the AI award. For interest of this conversation, we're particularly encouraging applications around triaging, imaging, which I'll come back to in a second, screening, and intelligent operational automation. The other one I want to call out is the AI regulatory system. So we did some work a year or 2 back now with an organization called Reform that mapped out the regulatory landscape of all the various types of stakeholders that you need to engage with if you are innovating. And for anybody that has tried to do this will know that this is acronym soup. So we are working with the regulatory bodies as part of NHSX, but specifically on the AI side of things, we're working with the main regulatory bodies to look at a multi-agency advice service, so joining up regulatory advice and approval services. This is a new service aimed to give innovators and healthcare providers that are developing AI technologies a one-stop shop for support, information, and guidance on regulation and evaluation. The main bodies that are participating in this project are the National Institute of Health Excellence, that's NICE, the CQC, the Care Quality Commission, the Medicines and Healthcare Products Regulatory Agency, MHRA, and the Health Research Authority, HRA. We are also working with MHRA on some things like synthetic data. So the MHRA succeeded in developing, quite amazingly, some synthetic data sets which mimics ground truth data so closely that can be used to validate algorithms, specifically including AI algorithms in medical devices, in a project that was funded in June 2020 through the Regulatory Pioneer Fund, and we're looking to work with them to continue this excellent work. One of the other things in terms of regulation is on post-market surveillance. So we're working with the MHRA, helping them to transform the yellow card to support for adverse incident reporting. And this will include a requirement to report all incident types, including software and AI as medical devices. And I'm happy to talk about that in more detail. The other one I'm going to talk about is AI and imaging, because that's what my current job is. And if we go to the next slide, if that's okay. I'm going to talk about some work that we've done during the pandemic. So we do know that artificial intelligence technologies applied to imaging, such as cancer screening, are some of the most advanced uses of AI in healthcare. And the adoption of these technologies has a significant potential to both improve care outcomes and reduce costs for the NHS across the UK. To ensure the opportunity of using AI in imaging and ensure it's shared across the NHS, the lab is working to support the development of imaging technologies, specifically from mechanisms used to safely collect and share data to validating AI imaging software. And let me play this out in the work that we've done during the pandemic. So we move to the next slide. We have built something called the National COVID Chest Imaging Database, the NCCID for short. It wasn't our most creative acronym, but ultimately, this is a collaborative exercise with ourselves as the lab, the Royal Surrey NHS Foundation Trust, the British Society of Thoracic Imaging, and a number of centres of excellence who are working to support us in collecting images so that we can help organisations train algorithms. And also what we're looking at doing next is ultimately validate, do those technologies do what they say on the tin? We can talk about that more in the Q&A. And ultimately, this is around making sure that, you know, we have a lot of technology companies coming to us promising that they are the panacea to all our woes. And we want to make sure that we have the mechanisms in place to ensure that they are safe for things like we're going through during the pandemic. The next slide kind of covers out some of the things that we're hoping to get out of this program and the various use cases that we want. For example, developing imaging processing software, so being able to risk stratify COVID patients, modeling, and ultimately looking at mechanisms of how we validate AI models. One of the challenges we did also discover during the pandemic was that there was quite a lot of commissioners and quite a lot of people being approached by technology companies with the promise that their solution was going to solve all their problems. And to manage the volume of questions to our inbox, we have set up a document that can be found on the NHSX website, which is the AI Buyer's Guide. And it's an attempt to ultimately explain some of the processes and things that people need to think about when they're thinking about buying AI technologies. And we hope that's of use. If you do have any additional bit that you would like to add to that, we want to keep that as a live working document. I will put a full stop in that and look forward to having any questions.
Thank you, Dominic. Sorry, I struggled to get myself back off mute there. Apologies. A question, one question before we go to the full panel for Dominic. If anyone's listening to your talk there, Dominic, particularly around the award programme, if anyone wants to get involved with this, how do they get involved? You know, what kind of support can be offered around that?
Yeah, so that's a fantastic question. Thanks for asking it. I think one of the things that we want to really strive to do is be collegiate. This is not about us sat in a black hole in the centre trying to figure things out on our own. So we have set up through the NHS Futures website a mechanism for you to come collaborate with us. Obviously, if you're looking for funding, you can go through the NHS AI Award, where we can work with you to get your technologies potentially funded. But I think everybody brings a various mix of skills and capabilities to the conversation, and we would like to have that ongoing conversation with you as we build out programs, as we think about safety, as we think about validation, etc. So through the NHSX website on the AI Lab, there's a link directly to the community that we're building out to make sure that we get your voice heard through all our programs.
That's great. Thank you, Dominic. Right, can we go to the full panel Q&A session now then? The first question I'm going to ask, I'm probably going to direct to Zoe initially, but I do wonder whether Dominic or Abby might want to join in. But you know, so it's been posed that artificial intelligence is no doubt an important development, but how can we make sure health literacy and digital poverty issues, with the divide increasing as a result of COVID, are addressed effectively? So Zoe, do you want to kind of enlarge on your experience of what demographics have accessed in Wales?
Absolutely. So I don't think it will be any surprise to anybody that's joined today that that's probably the first question that came to us, and certainly some of our GP colleagues were very anxious about who we were therefore excluding. And I will be honest, we learned from our experiences, and the nature of the pilot, aside from the actual system, was very time limited, and we had to get a certain number of patients through that system. So initially we looked at this being the only access route. So in the same way a lot of other services during the initial phase of COVID kind of shut up shop, we kept urgent only appointments available, but our routine was very much ground to a halt. So we looked at this being our initial way to reopen our services. And I have to say, we learned quite quickly that having Physio Now as the only option was not suitable in terms of ensuring that we were being accessible and equitable to all of our populations. And we do cover a number of areas with some significant deprivation, and we're very, very aware. Having said that, Gary, one of your colleagues from Connect Health, has been massively influential in gathering the data. I've obviously got another role, which means that doing all of this is hugely time consuming, but collecting really detailed data about who is referring, when are they referring, what is their age, what is their background. And we've done a piece of work, I'm sorry I haven't got the slides to share with you, but almost overlaying what our normal referral patterns look like and what our referral patterns through Physio Now, and actually the geographical basis and the age distribution looks on the surface to be very similar. So our old ways of paper referrals or GP referrals or whatever that looks like doesn't look that dissimilar to what we've seen in a very short period with Physio Now. We would obviously need to have a much longer episode of pilot to be able to really robustly tell you that that is 100% the case. I think our lesson learned is this can't be the only access route, and we shouldn't disadvantage somebody because they don't have digital access. They wouldn't go further down the waiting list or anything like that. That's really important.
Thank you, Zoe. Dominic, do you have a kind of a view on how that fits with the wider kind of agenda around AI?
If you can repeat the question, I'm getting a little bit of feedback on my line, so apologies.
No problem. So we were kind of sorry, I've now lost the question that I was asking. Bear with me a second. We were looking at the fact that AI is important, but how can we make sure that digital health literacy and digital poverty issues don't increase and they're addressed? So it'd be interesting to kind of see a view from NHSX on that.
Yeah, absolutely. And so we're doing a number of different activities to make sure that we do address any potential inequalities. And my colleague Brummy, who heads up ethics and equality, is doing quite a lot of work with us, and we're looking at hopefully over the next couple of months to make some announcements about some programs or activities that we're looking at specifically around inequalities, and inequalities in terms of like what's available through data sets, through ethics, etc. The other bit I think you're alluding to, if I understood the question right, is what is the digital capabilities? So we're working with Health Education England through our activity to make sure that we feed directly into that. And there are a number of ongoing there's been an ongoing conversation about literacy for quite a long time, even across the analyst community, about the literacy around being able to develop algorithms or being able to understand statistical analysis inside our organizations. So I think it's a multifaceted problem. and Health Education England as the body for that have been working closely with us.
That's great. Thank you, Dominic. I'm going to move to the next question. That is probably one for a combination of Pete and Zoe, and I can support as well if needed. But we've got a cluster of questions that are really kind of around red flag questions within Phio and Physio now. So kind of to summarise them, we've got how much development was required to Phio to make it clinically safe. How do we ensure that what happens if a patient does kind of trigger red flags? How do we make sure they go to ED promptly, and what safety mechanisms do we have in place around that? And also there was a question there about how do we make sure we don't overburden emergency resources. So perhaps Pete, initially you could answer that one.
Yeah, thanks, Helen. So I think, as you know, with the work that we've been doing, but effectively making sure that we get proper clinical review on the outcomes as they're coming out of the back of the solution, and having robust systems in place to also kind of sense check onward referrals where they occur. But I think you've had some interesting data. I know one of the case studies that I think you recently prepared, where actually the data is showing that in effect what we've been able to do in certain areas is actually significantly speed up the rate of referral into emergency department where it's been 100% needed. And I think there was some cases that I think you had internally, but I think at a kind of high level, it's really just about making sure that initially when we design the system, that we use expert opinion, that we sense check what the local frameworks are, that before anything goes live, it's subjected to significant rigorous testing, both with real life examples and synthetic examples, i.e. running through numbers of scenarios to make sure that the outcomes are where they need to be. But then when it's also being deployed, it's actually the way that it's intended to be used is that it is checked, the outcomes are checked and validated. And as we know, there's been some good data around what the acceptance rate is there. And that there's an ongoing process of, again, checking that, not getting to a position where we become reliant that it's working, but continually sense checking and continually updating. And as we know, evidence changes, research changes, particularly thoughts around cauda equina are subject to some change. And actually just making sure that we have an open communication with the people that we use our technology with, and that we're able to deploy, update changes where they are necessary and where the regulation suddenly may change or the frameworks may change. So yeah, I think it's a combination of getting it right before we start, and then checking it's right when it's working, and then learning from the process and updating the decision tree to make sure that it is obviously as accurate as it needs to be.
Thanks, Pete. Zoe, do you want to comment on that at all as well?
Yeah, so I think probably the best way to explain is to tell you a story. We had very first, the week before we went to go live, we had a test link that we shared with our clinicians for them to see what a patient was going to see. And one of them thought they would test it out. So they answered the questions in the way you never want a patient to answer these questions. And within about 45 seconds, I had a phone call from somebody to say, is this a real patient or is this somebody testing the link? So it is being constantly monitored. Anything that flags up is dealt with appropriately. The only thing I would say is that in the same way as a physio in a department or a GP in a practice, we don't have control over whether that person decides to turn up to A&E or not. If we direct them to 111, ask them, tell them we're concerned about their condition, for example, if that's what gets generated, that's the individual's responsibility. And whether that's for us, whether that's different to how your services currently work, that's probably an individual service level implementation that needs to be explored. But to me, we would advise people to do that now, and whether they end up at the end of the corridor or in their car on the way home, we don't know.
Yeah, I'll throw in a little bit from my perspective on it. It is quite interesting. We don't have high volumes nationally go to NHS 111. We've worked very hard and used patient engagement as well on the questions to make sure that because I think someone made the point on the Q&A that actually you have to ask a lot of questions to clarify CES and work out is this a bladder issue or not. And we spent a lot of time with patients making sure that actually the written version of this does make sense to them. So we do send less than 5% there. Out of that 5%, we find less than 50% actually take the advice of contacting NHS 111, which is why we have in the outcome kind of wording it is we advise you to do this, you've got a potential serious condition on the next available working day, because at the moment, as we alluded to earlier in Zoe's talk, most physio departments on Monday to Friday 9 till 5. Someone will contact you, so in an awful lot of cases it is the clinician that then contacts them and actually does a second screen. So patients, do understand sometimes that their symptoms might not need to go, but in general, in all the scenarios where a patient has needed to go, they have actually, all the ones that subsequently had CES or metastatic cord compression, they have actually taken urgent care. Okay, I'm going to just jump to a question probably that's more for Abby, I think. The question that we're looking at was kind of what is the kind of cost to trial software for AI triage? Particularly in Wales, have you guys done your cost benefit analysis? What do you think that will it have a cost benefit for you within the services, and how will that look?
So funny enough, we were talking about this on the evaluation call earlier this week. So I don't think it's going to be a cost benefit analysis because, the pressure that's on healthcare services often means that this might better manage demand as opposed to kind of do away with clinicians, which we're never going to do. So there could be a benefit to time. So time spent by clinicians, time spent by patients waiting. And obviously they're really important things. We're also keen to have positive experience measures and outcome measures as well. So yeah, I'm not 100% sure on the cost benefit. I mean, for us, it's well, publicised that we set sort of up to 30k budgets for these projects, and this particular one came in just under that. And I think given that with the COVID-19 pandemic, it could potentially be no physio or this, then I think, we've probably more than had our money's worth. But yeah, it's a very difficult thing to do, particularly when you start talking about cash releasing benefits, because they're just very difficult to achieve in these types of projects.
That's great, thank you. Probably one for Dom next, if that's all right. Is there any document, Dom, that discusses the data warehouse for IS readiness for implementing AI in the NHS?
I would like to try and get to the bottom of what this question is trying to ask. So if they're asking for where there are data warehouses, or just so I can.
I think it's asking, is there any kind of documentation that helps maybe identify what standards data warehouses and everything needs to be in prior to readiness for MI and for the AI?
So there are a number of activities across NHS D, E and X around data quality, and there are a number of data sets that are already being developed. If the question's around the standard itself, yes, there are standards sat within NHS Digital about the types of things you should be including in your data sets. When it comes to implementing ML and AI, which I think is probably the question that's really being asked, like how do you identify whether the quality of data is representative to be able to both train and independently validate whether an algorithm is safe for deployment? That's something that we're playing out at the moment through multiple conversations about how do you do this in a robust enough way so that it is above and beyond some of the activities that people do to get their accreditation that the technology meets a CE marking. And we can come back to this in more detail if people want to have a discuss about that. But in terms of readiness, it really depends on where you sit in terms of the whether it's first off, is it a medical device? What is it you're trying to do? And the kind of steps that are needed to regulatorily approve your technology. I'm happy to pick that up in more detail if that's not even addressing the question.
I think that's really helpful. Whilst you're there, I'm going to ask you the next question as well, Dom, but I wonder if Pete would like to come in on it second. So it kind of is a bit around kind of clinical knowledge. So is there a level of clinical knowledge and experience that we really need to be able to effectively integrate AI? So I guess we're talking about here the difference between novice and expert. And I guess this really relates to actually within the healthcare workforce. What do we really need to do to kind of upskill, or is upskilling needed? You know, if we're a novice, is AI going to be okay, or how do we need to upskill? So probably it relates back a bit to what you mentioned before, Dominic, about some of the agenda within NHSX, but maybe if you could answer that.
So if we're trying to understand the clinical capabilities of individuals before they use AI?
So I think it's the digital competence of clinicians, how that will impact on the effective integration of AI.
Yeah. So I think this is where I struggle generally when we talk about AI, because AI as in itself is a broad science. It covers quite a lot. It's a bit like saying, do you understand the science? I think where we need to get really practical is in the real world use cases. So would a radiologist be comfortable with a decision, with an augmentation to say that there is pneumonia on a chest in a particular area to support them in their diagnostics? They're the type of things that we need to be clear on. So are clinicians ready to be able to use these technologies above and beyond the existing tech that they have? I think it varies. I think it's part of the wider digital capabilities that we have in the healthcare system about, adoption of AI technology, or not even AI, adoption of technology generically. There is an appetite for some people who are a little bit more ready to look at AI. And you see this in the working groups of the people that are having these conversations. They can see the opportunity and the helpfulness of some of these technologies in their workplace. But as others have mentioned, there are some that are not being engaged, and how do we keep them motivated that this is a potential solution to help them?
Thank you, Dom. Pete, do you have anything to add, perhaps from a physiotherapist perspective who's interested in AI?
Yeah, for sure. I think, and Dom's absolutely right. I think it is a very broad area. There's lots of different ways to apply AI. There's a lot of confusion around AI, and I think there's a couple of things that need to be unpicked there. I mean, first of all, we owe it really as the innovators or the people working in the space to be able to provide clear explanation as to what the system does, what it absolutely doesn't do, and what the parameters of use are. And I think that's more of a broad thing. But I think, and again, Dom mentioned some of the great work that the guys over at NHSX are doing. But obviously, when we're developing and deploying a solution, we need to make sure that we fall within the regulatory framework that we must abide to as part of that solution. And things like post-market surveillance are really key. And I think interestingly within that, and effectively that is how do we check that it's continually safe when it's being deployed. And effectively, there's some interesting kind of challenges to overcome just with that process in itself, because if you consider that, one way is to check the outcomes with clinicians, but how do you know the clinicians made the right decision, or how do you know that there isn't bias? Well, there is bias within the clinician's decision. So, and we already know that. I mean, the current system is already heavily biased. So it's not an excuse to say, well, your AI can be biased. But what you do have to do is come up with strategies that can effectively mitigate against that risk. So it's how are you getting additional information back? For example, you send someone to A&E. It turns out they had a diagnostic. What does the diagnostic say, or what was the follow-on opinion? And I think that's really where, again, I mentioned it in my piece around where I really think the power, particularly the power of some of the technologies that we're looking at lies, is in that ability to look at that data, particularly to be able to look at that closed loop data, which is where you get full end-to-end transparency over a patient journey, and then start to kind of distill some of the insights out and see where some of the inefficiencies are. And I think by creating systems that effectively have these sensible sense checks built into them as part of their design, I think that's where you start to get confidence in its ability to be able to be deployed to providers, and they get comfortable that the decisions that it's making are correct, and that the safety mechanisms are in place. But yeah, it is a really important point. You know, do people understand what it's doing, and are they comfortable on the decision? And I think, you know, I think that's for us, that's for me, that's for Equal in terms of what our vision is, to really outline that and make sure that we are clear about what it's doing and what it's not doing. So yeah, I think it's an interesting point, and lots of areas to consider. And yeah, I guess that would be my view on it.
Thanks, Pete. I think probably one that follows really closely to that, a question that's been posed is, I think you've answered part of it between both of you, but if there's maybe just a bit more that you could add about do you kind of use any behavioural insights or science methodology when you implement and evaluate in models or products that are AI?
Dom, I'm happy to kick that off. I mean, again, I can only talk about this from my perspective and what we're building, but I mean, we absolutely include as much information as we can include. So, you know, it's not just biological information, but there's the whole psychosocial element, the psychological component to what we do. And you know, MSK is a complicated area. I mean, it's difficult to define at the best of times exactly what the area of MSK is, because it does cover so many different broad areas of healthcare, and it has such a vast impact on so many different areas. But I think what we have to do is make sure that we use good research that we've sense checked and validated that meets the criteria that we need to use. But I think it's also not just about having evidence, but having, you know, evidence from experienced healthcare professionals, evidence from trials and tests that have been run. As I say, the post-market surveillance piece where we're looking at what's going on when it's being deployed. And again, being able to build in things like general epidemiological data and risk factors. But again, it does kind of uncover another area of where AI can become complicated. You know, if you can identify a risk factor within a certain group of people, to what extent are you training an AI that then goes and assumes that that group of people always has that risk factor? Well, that's an important feature, but equally it's something that needs to be monitored closely, because you can start to build inherent kind of bias into the system that then assumes that anyone in that demographic group that presents with that risk factor has this problem, whereas as we know, that's just not the case. So I think it's about making sure that we use a broad spectrum research, clinical opinion, rigorous testing, and effectively by combining those processes together, that's where we get comfortable with what effectively is being developed.
Thanks, Pete. Dom, do you have anything to add? Or?
I've nothing. I think Pete summarises it quite well. I think, you know, just for reassurance for people, I think who are probably new to some of this field, we have a very robust regulatory system in the UK. We have bodies that are exploring this work with us about how do we embed further safety and mechanisms to do that. You know, NHS Digital has published guidance for those who are new to some of this stuff around, you know, clinical risk management, and you need to do this for any type of digital health technologies. So we need to, you know, I think we're embedding this on top of existing good processes of making sure that technology is robust. It's not to say there isn't more work we can be doing, because there is, and but I just want to kind of reassure people that there are processes in place that doesn't.
Thank you, Dom. Yeah, I think that's an important point to make. I'm going to move the next question to Graham Fletcher, who's the Chief Information Officer at Connect Health. Graham, we had a question posed about how do we get Phio to integrate into our clinical systems, or Physio now, and additionally, there was one question about what's the difference between Phio and Physio now. Physio now is the Connect Health version that is powered by Phio, and Phio is the platform and that it relies on. So I'm going to move to Graham for that question about how do we get it to integrate, please.
No problem. Good afternoon, everybody. I think it's an interesting question, and one of the key challenges we have in a lot of the healthcare world, and particularly our state, is how we get systems to talk to some of the big clinical apps like System One. There's not natively available integration and APIs and readily available platforms that we would normally use. So in this instance, what we decided is we already have a fairly sophisticated robotic process automation platform sitting in the cloud, and we'd already built that and implemented it to do patient registration and stuff, because it allows us to do 24/7. It frees our people up to do more value add work. So what we did is basically use that technology to allow Equal to talk to our System 1 clinical application. And what that gives us is it gives us a way of then not having a load of humans having to do that interaction, which is low value add. It allows us to do it 24/7 should we need to do that. It allows us to scale so that we can handle as many transactions as we like. Within that, it has its own AI implementation inside that platform, as in it intelligently understands where the load is, and we can kind of swarm more virtual workers at any time of the day or night over where the loads are, because obviously it's not the only thing we use. And I think it's it was just a little bit something we wanted to make sure that we didn't end up with having to have, we need humans in the process where it comes to some of the more clinical decisions, but when it comes to the administration, we just didn't. So we built that in and allowed us to move that forward, and it just gives us lots of different ways we can play with that going forward. So does that answer the question?
It does, Graham. Thank you really very much for that. We're nearly at the end of the webinar, really. So I've probably got a question for each of the panel, just to close with here. What if you could sum up in one sentence, each of you in turn, and we'll start with Zoe. I'm not going to give you much time to think about this, am I? What would you say the best thing is, in your opinion, about digital transformation?
Putting the power back in the hands of the patients, that they can choose as, when and how they access healthcare.
Thank you, Zoe. I'm going to go to Abby next.
Well, I think I reflect on, you know, how we've digitally transformed as an organisation, which has enabled us to all work from home. And it's, you know, from a clinician perspective, then I would say it's probably a better work-life balance.
Thank you. I'm going to go to Pete for the next one.
Yeah, I think for me, it's about accessibility, it's about engagement, and it's about clinical appropriateness.
Fantastic, thank you. Graham, I'm going to come back to you and put you on the spot.
I think for me, it's allowing our humans to move into a more value-add place, particularly with what we've talked about in the world I've just dealt with. Take away some of the manual labour and let them focus on more important stuff like the patient.
Thank you, Graham. And Dom, last of all.
Yeah, I have a book recommendation that I think answers this question, which is Eric Topol, who did a review of digital health for us 2 years ago when Jeremy Hunt was health minister, because like many lifetimes ago, has a book on deep medicine and how AI can help make healthcare human again. And I think this is the point, like we want to use, this is not an overburden, this is about removing some of those burdens so that we can, you know, with our limited resources of staff, how can we help them do the best to support the patient? And I think also what the other person said about, you know, handing some of the power back to the patient as well.
That's great, thank you very much. So last slide, please. Thank you all for joining the call today. I hope you found that enjoyable. I hope you found that informative. I'm sorry that we haven't got through all the questions. There's never quite enough time, but I know that some of the panel have been valiantly answering them away in the Q&A as well. We really hope that you could join us again on another webinar in the future. We have our mental health at breaking point coming up on the 2nd of December at 12:30. So please sign up to that if you're interested. And then in January, we have a QI quality improvement one, and the 10th of February, we have a webinar on chronic pain NICE guidelines. Look out for the recording, and we will do a summary Q&A. And thank you again for your time today. Thanks to all the panelists as well.